So next is we are going to see is operative deliveries. Okay. No. Outlet forceps is used at what station? Head on perineum and plus 3. Okay. See, operative deliveries now it's going to be two things. That is major. Um, One is going to be forceps, another one is vacuum or ventouse delivery. Okay. So first is what is forceps? Forceps is nothing but an instrument which is used to deliver the baby out. Okay. What and all you can do is you can do traction, this pull, or you can rotate, or you can lift. All these things can be done. Okay. There are different types of okay. So there are different types of forceps. First, when and all you do forceps there is when and all you do forceps deliveries, there is a lot of indications, maternal and fetal indications. Most important being where there is going to be a prolonged second stage of labor, and second is going to be in fetus. It's going to be a hypoxia. There is compromise, fetal compromise. So immediate delivery. In all these conditions, you are going to do a forceps delivery. Okay. Whereas contraindications is when you should not do is when there is going to be a there is when there is no imminent delivery. That is, for example, if the cervix is not fully dilated, or there is going to be unengaged head. Okay. Or it is going to be a malpresentation. Okay. Or there is going to be CPD. Understood? So in all these conditions, and also if the presence of caput. Caput is nothing but caput succedaneum. It is the what to say, the edema that is actually seen in the caput, okay, which indicates that there is going to be, there is already a prolonged labor, and further if you put a forceps and complicate sometimes there can be trauma and injury also. Okay. Now what are the complications? Of complications is going to be obviously injury. Injury is the first foremost thing, both on maternal and the fetal side. Okay, anywhere and everywhere injury, hemorrhage, hematoma. Understood? That only will happen both in the fetal side as well as in the maternal side. Okay. There are three types of forceps. One is outlet, low cavity forceps, and mid cavity forceps. Outlet forceps is the most common forceps that actually we all do. It is done on when the head is on the perineum or in the +3 station. Okay, and the scalp should be visible, and the skull has already undergone all the rotation and everything. There should be no further rotation. Okay, the sagittal suture is in the anteroposterior diameter, or the rotation is not more than 45 degrees. Okay, there should be no further rotation. Understood? Sagittal suture in the sense that is the central suture should be in the anteroposterior diameter. That is, here should be pubic symphysis and here it should be sacrum. Okay, so the sagittal should be like this. So only then the side of the baby head you can apply the forceps and pull the baby out. You understood? Okay, this is outlet forceps. Low forceps is when the fetal skull is at above +2, or that is at +2 or just +1. Okay, the rotation is 45 degrees. Okay, and next is mid cavity forceps. Is where it is 1/5 palpable, that it is way high. Okay, too high a forceps where the rotation has not happened at all. So what happens, sometimes rotation can be done or sometimes rotation may not be done. So the rotation is either less than 45 or it is more than 45. So sometimes you need to rotate and then bring out, or sometimes it doesn't need any rotation. Okay, that is, these are the three forceps. You have to remember outlet forceps, which is done at +3. Okay, yes. Next is the different types of forceps that the named forceps, Wrigley's, Simpson's, Milne Murray, Keelan, Piper, all these. So இதில் நம்ம learn பண்ண வேண்டியது என்னன்னா, Wrigley's forceps is outlet forceps and Piper's forceps is a breech forceps. Okay, so here see, Wrigley's forceps is very short, nothing, just one curve. That is the Wrigley's forceps. Okay, whereas Keelan's forceps is mid cavity forceps. Mid cavity forceps will have a long shaft. Okay, will have a long shaft. Whereas axis traction forceps is where you need to you have a traction handle so that you can pull it in either way. That is, you can pull both down as well as both up like this. Okay, this is action traction forceps. But Understand that Wrigley's outlet forceps is a very short and stout one, whereas Keelan's or any mid cavity or low cavity forceps will have a long shaft, so that the what to say, the forceps has to go deep in. Okay. Now, what is the use of this instrument? What is this instrument first? It is Wrigley's. Yes, actually speaking, it is Wrigley's forceps. Okay, because it has not got any shaft at all. Okay, so it is Wrigley's forceps only. Now, where do you use this instrument? See, generally obstructed labor and all, you have to go for cesarean only. You can't do anything. Where else you can use this forceps? Here it is given. Actually speaking, occiput or posterior can also be an answer. Occiput or posterior also you can do delivery. Here they have given is obstructed. See, I generally will say obstructed labor. Oh, correct. Oh, sorry. Yes, that is the answer then. Okay. Sorry for I only read it wrongly. Okay. So, obstetric labor is where the instrument is contraindicated. You go for cesarean section. Okay. Right. யூஸ் பண்ணலாமான்னு கேக்குறீங்களா? அதுக்கு அதுக்கு கேக்குறியா? பண்ணலாம். See, actually speaking, head delivery in cesarean section can also be aided by vacuum as well as by forceps. Most common is going to be um, vacuum. Okay, vacuum is where we along, that is if the head is going to be stuck deep inside or it is just rotating where we cannot pull it outside, in those conditions we can actually go for, yes, vacuum or forceps. Okay. Yes. So here, where is it contraindicated? Obstructed labor. Yes. Okay. Which of the following is an outlet? Which of the following is an outlet forceps? Yes, Wrigley's is an outlet forceps. Okay. Identify this forceps. See, இதில வந்து we know outlet, that is Wrigley's, it's not Wrigley's. Okay. The only forceps that we actually read was Piper and Keeland. Okay. Now, already I showed the picture. Where is it? See, this long shaft. What forceps is this? Keeland's forceps. Okay. Right? Okay. Others and all you don't have to confuse now. Vent-house delivery is contraindicated where? Yes, good. Actually, vent-house delivery is contraindicated. Not contraindicated, not indicated. Where it is contraindicated? Actually, yes. Preterm labor. Contraindicated. I'm sorry, I'm getting confused with indication and contraindication. Contraindicated in preterm labor. See, actually, forceps and vacuum, if you take, forceps can be applied only if the labor is completely, that is what to say, that is the labor is completely established, that is full cervical dilatation is needed. Okay, the head should be visible properly. Okay, and the head should be on perineum for outlet forceps. Okay, for it should be on perineum for outlet forceps. Okay, and the next thing is whereas for vacuum full cervical dilatation is not needed, and also premature, that is in forceps can be used in, actually, that is vacuum should not be used in premature fetuses. Why? Because premature fetuses tend to rupture their blood vessels and there can be bleeding on applying suction. You understand? So generally for preterm or premature fetuses we generally tend not to use this vacuum. Okay, for that matter, it's not that we can use, that's why I striked it off. It's not that we can use forceps left and right. No, because fetal head, if it is preterm, definitely it might get injured more often. We already saw that is the more important complications of forceps is injury. Any injury can happen. Fetal head injury, nerve injury, even face and all can get injured in case of forceps delivery. So generally, forceps delivery, it is it is not that effective in case of preterm, but vacuum is definitely not in preterm. Okay, but here vent-house delivery is contraindicated. The answer is preterm. Can it be used in case of heart disease or 8 centimeter dilatation or decreased bearing down effects? Yes. Okay, because in case if the mother is not able to push, you do that is you put vacuum and then deliver. And obviously I already said that full cervical dilatation is not needed in case of vacuum delivery. Okay. So we create a negative suction between the scalp and the cup, and it forms a chignon. Chignon is nothing but a different word for captive succedaneum that is formed in the venous delivery. Okay, and then we pull the baby out. Understood? So advantages is going to be less maternal injury. See, it is going to be less maternal injury, and obviously the birth injuries are also very less. So all the injuries which is done by the forceps is very less. Okay, but whereas what are the disadvantages? Disadvantages of hemorrhage and hematoma, because as you create a suction, obviously there's going to be rupture of the blood vessels and it can create hemorrhage or hematoma. You understand? Yes. And obviously it should not be used in the case of premature fetuses. So what are the contraindications? Premature, less than 34, and then there is going to be an increased risk of fetal intraventricular hemorrhage. Malpresentation. Malpresentation, there is no role for vacuum. Whereas malpresentation, forceps can be used, because forceps can be used in all the malpresentations like occipital posterior, or it can be even breech also. There is a forceps which is called as breech forceps delivery. Okay, but breech, it's not like you are going to pull the breech, the head of the breech. Okay, that can be delivered by that can be delivered by forceps. Okay, and then contraindication is once again cephalopelvic disproportion. It is nothing but in case you feel that there is a disproportion, the baby will not come out, it will go in for obstructed labor. Never try any obstetric delivery, operative delivery. You directly go for cesarean section. Understood? And then any bleeding disorder or infection. Okay. What are the prerequisites for vacuum extraction? Must be cephalic. Yes. Engaged head. Here this it says cervix will be fully dilated, but it is not a definitive prerequisite. There should be no cephalopelvic disproportion and the bladder should be healthy. Okay. Uh, Forceps delivery. Okay. Complaints of pain. BP has dropped. Tachycardia has come. Episiotomy site shows bluish discoloration and swelling. What is the what should not be done? Yes, compare the stitches in the ward, which is very risky. Okay. Again, the same thing in a different way. 80, 60, bluish discoloration. What is the best? What is the next best step in our management? BP is down. She is having some bluish discoloration. That is, there is some hematoma. What do you do immediately? Yes, shift the patient immediately and explore. Okay, good. During vacuum delivery, the suction cup is ideally applied over which area? See, it has got a point, pivot point, okay, which is between anterior one third of the anterior fontanelle to the posterior one third. Okay, that is anterior one third, anterior one third. Actually, this posterior two thirds. That is the place where you apply the suction cup. But actually, see, we cannot see all that and apply. Very, very difficult. It is very, that is, you should make it sure that you're applying in the vertex. Okay. So once operative delivery is not giving any result, or it is failed, or the baby, that is the fetus is cannot be delivered by any operative method, then the next operation that you would take up is cesarean section. Okay. A lady with the previous lower segment cesarean section presents with occipital posterior position. What is the next management? We'll see. See, cesarean section is obviously the delivery of the fetus through the abdominal wall. That is laparotomy. Okay, and hysterotomy. So you open the abdomen, you open the uterus, and then you deliver the baby. Two types of cesarean. Either it is emergency or elective. Okay. It can be primary or repeat cesarean. Okay. Or it can be lower segment cesarean or classical cesarean. Okay. Yes. So what is the advantage of lower cesarean, lower segments? Easy suturing, decreased bleeding, and future there is no uterine rupture, and also bladder bowel and all will not get any injury. Okay. Now, there are various indications of elective cesarean section where you know that the baby will never go into labor. Okay, elective can be either it can be a primary elective or it can be a repeat elective also. Okay, what is the most common elective surgery that is done now is elective repeat cesarean section is only the most common right now that is being practiced. Okay, so elective cesarean sections, the most common is going to be see, previous cesarean section, or there is going to be any placenta previa. Okay, placenta previa is it there, and then there is going to be what? Mm, any dystocia, soft tissue dystocia, pelvic deformity, and all that. And whereas here it is going to be CPD, that is severe CPD, severe forms of CPD, growth restriction, twin pregnancy, malpresentation, macrosomia, all these conditions you never allow the baby for vaginal delivery. Okay. And when do you go for emergency cesarean section is, this is, see, here it is going to be CPD, where here you go for a trial of labor. Okay, I was speaking about it now. That is mild CPD. You can go for trial of labor. In the first few slides we were seeing, in mild CPD you can go for trial of labor. If it is that is not working out, then you go for elective, I mean emergency cesarean section. Whereas in case of severe CPD, what do you do? Severe CPD, directly the baby will not enter. So you directly go up for elective. Okay, correct? And then while doing labor, if there is any complication like fetal complication or there is any arrest, induction arrest, anything. Okay. Yes. So lower segment is, in the lower segment, classical is from upper to lower segment. Okay. So what is the anesthesia that you go for? Regional anesthesia, spinal anesthesia. Okay. Incision is going to be suprapubic transverse. Okay. And then transverse uterine incision has got its own advantage. Okay, initially they were putting midline incision and then RPM, that is right side midline incision and all they were putting. But now transverse incision only, and transverse incision even in the uterus. So in the uterus, what are the advantages of transverse uterine incision that we have already seen? Blood loss is very less, approximation is very good, bladder doesn't get injured more, and the last is low risk of rupture in subsequent pregnancy. Okay. So complications, see any surgery, the complication is going to be trauma, okay, bleeding, infection, understood? So that is all trauma to any organ. All these are the most common complications that can come out of any surgery, okay. And in this, there is another special thing called scar pregnancy, scar endometriosis, and scar rupture in the future. Understood? So these are the other complications of cesarean section. Okay. Now, TOLAC. TOLAC is trial of labor after cesarean. We studied already trial of labor in CPD. Okay. Now, what is TOLAC? TOLAC is trial of labor after cesarean. In trial of labor after cesarean is, what are the factors which predict is if there is going to be a previous history of vaginal delivery, or if the labor onset is very that is, it is onset is spontaneous and the fetal weight is very less, that is the fetal weight is very average, and not current indication for a previous cesarean section. Aதாவது, if at all the previous LSCS has happened due to some recurrent indication, like for example recurrent indication in the sense what, some uterine anomaly, okay, some tumor. Okay, so all these can be recurrent indication. That is, it will be permanent. It will be there for this delivery also. So you don't go for trial of labor. You directly go for elective planned cesarean section. Understood? So what are the factors? You need a previous normal delivery or any spontaneous labor, any fetal weight. If it is fetal weight should be normal. All these are factors which predict successful TOLAC. So what are the ones which decrease TOLAC? Okay, that is previous cesarean sections for dystocia, post-dated pregnancy, bigger babies, or even smaller babies also for that matter. And then delivery interval is very less. Okay, and maternal age is very advanced. Or see occipito-posterior position and deflection. All these are and obese ladies. So anything if you see, you find it is not very favorable. They will not help TOLAC. Okay, TOLAC can happen only if the mother is very young and she is of average weight and she has no recurrent indication and fetus is also in average weight and there is no CPD. Okay, and any previous vaginal delivery if it had happened. Okay, contraindication. When do you not do any high risk uterine scar, any previous uterine rupture, or any other complication? You never do TOLAC, trial of labor after cesarean. Otherwise, if you allow, the scar will go for dehiscence. That means scar will give away. It might result in uterine rupture. Okay. So what happens? The baby's heartbeat will change. Mother's heartbeat will change. Maternal tachycardia will happen. Finally, shock will happen. Mother will go for shock. Baby will go for shock and die. Okay. And if the scar has given way, what happens? The parts of the baby, that is fetal parts, will be easily palpable on the abdomen. Understood? Yes. When do you go for cesarean hysterectomy? Cesarean hysterectomy is done in case of abnormal placentation, that is placenta increta accreta syndrome. Okay. Placental adhesion syndromes, PAH. Sorry, PAS. Placenta accrete, that is placental adhesion syndromes, and then it is postpartum hemorrhage and cervical cancer. In all these conditions, you have to go for cesarean hysterectomy. Okay. In those cases, generally subtotal type of hysterectomy will be performed because total hysterectomy is where you remove the uterus as well as the cervix. But subtotal hysterectomy is where you just remove the uterus and leave the cervix. Okay. But here we generally do total hysterectomy because we don't have the time to do a detailed surgery. It is all done for emergencies. So immediately you just check off the uterus and close and come. Understood? Okay. Now, lower uterine segment presents with occipito posterior position. What is the next best step? The answer is perform cesarean section. Why? Because occipito posterior position is not a favorable position for delivery, and this factor is not a favorable factor for TOLAC. Okay. Face to pubis. Superb. Occipito posterior position in which pelvis? Very good. Anthropoid. Very good. A lady presents with lower uterine segment. Okay, which is incorrect. Which is incorrect. See, actually, இதுவும் வந்து you go with uh, elimination tactics. No prior uterine rupture should be there. Yes. Spontaneous normal vaginal delivery should be there. Yes. And emergency C-section facility should be available. Yes. So the only left out is 4 to 9% of scar rupture. So that is the answer. This is not right. Okay. Multigravida female with a previous history of C-section presented in an ANC OPD. In which of the following condition vaginal delivery can be considered? Off the lot, which is favorable? Nothing is favorable. All the four are wrong. Okay. It is not at all in all the four parts. I mean, in all the four options, you never do TOLAC. Okay. But since it's a question that has actually come and it is a recent question where 2024 question. Okay. So the answer out of it, it is going to be preeclampsia, but never do. Please. Okay. Right. Next. All are contraindications of normal vaginal delivery except yes, previous macrosomia. போன வாட்டி தானே இந்த வாட்டி need not be like that இல்ல. It is a non-recurrent indication. Correct? Yes, super. Prolonged labor. Okay, hypotensive. Fetal heartbeat is not audible. Fetal parts are easily palpable. What is the diagnosis? Uterine rupture. Super. Okay, right. Previous three sections, low BP, tachy, USG fluid is present in the peritoneum with a non-reassuring fetal heart rate. What is the next management? What is the management that you do immediately? Yes, uterine scar rupture, laparotomy. That's it. You consider it as uterine scar rupture and go for laparotomy. Okay? Yes? Right. Next, once we delivered everything, all the baby is delivered, normal delivery conduct பண்ணிட்டோம். அது பண்ண முடியலனா operative delivery conduct பண்ணிட்டோம். அதுவும் பண்ண முடியலனா cesarean பண்ணிட்டோம். And now we are coming on to the puerperium. Okay. So what is the puerperium? Puerperium is in the period that is post delivery. Okay. Which hormone is responsible for this breastfeeding? Very good. Prolactin and oxytocin. What is the answer here? It is oxytocin. Yes. Okay. So what are the changes that can happen in the uterus? There will be involution. Okay. So involution, yes, nothing but the uterus shrinking. Okay. So it is getting shrunk and at the level of umbilicus எப்போ இருக்கும் when the delivery has happened. Okay. Soon after delivery, the uterus is at the level of umbilicus. So when does it become pre-pregnant size? After 6 weeks. Okay. Yes. And lochia is nothing but the discharge post delivery. Okay, so lochia rubra is, lochia serosa is the next, lochia alba is the third. So initially rubra means red in color. Next is going to be serosa is going to be fluidy in state, and alba is white in color. Okay, so these are the three stages. Understood? And what happens to the ovarian function? It is suppressed. So ovarian function is suppressed because of that is because of no GnRH. Okay, suppression of the ovulation due to high prolactin and suppression of the GnRH release. Understood? So prolactin is also high and GnRH is low. So there will be no ovulation. Okay, when that has come back means in lactating mothers, it is taking approximately 6 months. Okay, in non-lactating mothers, it will be approximately 75 days. That means 2 months. It will come back. Understood? 2.5 months to 3 months. Understood? So, this is for lactating and non-lactating ovulation. Whereas menstruation, when does it happen is, in lactating depends on the duration of breastfeeding. Depends on the duration of the breastfeeding, menstruation might resume. Non-lactating, it will take 8 to 12 weeks, 3 months. I said na. So ovulation and menstruation both approximately together, it comes in non-lactating. Whereas in lactating, what happens is, it will take approximately 6 months for ovulation and it will take approximately even 1 year. That is until the mother stops breastfeeding, the periods might not come. But the problem is, since she has already started ovulating, she might become pregnant in the lactational amenorrhea itself. You understand? Lactational amenorrhea is where she is having no menstruation during the period of lactation. Okay, but that doesn't mean she is not ovulating because ovulation starts by 6 months itself. So, changes in the breast, what happens? Estrogen is responsible for ductules, progesterone is responsible for alveoli. Okay, so this is the structure of the breast, and so what happens is four stages of lactation: mammogenesis, that is development and formation; lactogenesis, formation of milk; galactokinesis, this movement of the milk. Kinesis is nothing but ejection, so ejection of the milk. Last is galactopoiesis, which is maintenance of the milk. Okay, this is the order: mammogenesis, lactogenesis, galactokinesis, galactopoiesis. Okay, then production is by prolactin, release is by oxytocin. Okay, so estrogen is for ductules, progesterone is for alveoli. Okay, how does lactation happen? So there will be prolactin, milk production; oxytocin, milk ejection. Simple. Which hormone is responsible for lactation? Oxytocin. Good. Galactokinesis is governed by Oxytocin, kinesis is ejection. That is movement, correct? So that is by correct sequence of events. Hmm. Intellect, very good. Option C, very good. Superb. What is the reason behind the abdominal pain in the mother when she is breastfeeding? Oxytocin. Oxytocin causes contraction. Okay. Order of Lockyer. Superb. Rubra, serosa, alba. Lockyer lasts for how many weeks? 3 லோக்கியா வரணும். கண்டிப்பா கொஞ்ச நாள் எடுக்கும். அதனால வந்து we'll go with 4. It can go up to 6 weeks. Okay? Right. Which of the following is the cause of amenorrhea in a lactating mother? Yes, increased prolactin. Very good, very good. See, you are confident. Say it boldly so that it gets stuck in your head. Shariya? Right. A female after delivery complains of cramps. What is the hormone? Super. Oxytocin. Oxytocin will not do the following action. Very good. It will not cause milk production. Milk production is by which hormone? Yes. Contraction of the lactiferous duct of the breast is due to. See, actually speaking, contraction of the duct is not by estrogen. Formation of the lactiferous duct is what is estrogen. You understand? Duct order and the ductules are that is it has been developed by the estrogen and alveoli is developed by progesterone. But actual action is done by prolactin and oxytocin. Anything contraction oxytocin. Okay. With the uterus immediately after delivery. 1 kg. Okay. இதெல்லாம் வந்து just uterus becomes pelvic organ by how many days after normal delivery? Becomes a pelvic organ. You see, it's actually 12 to 14 days. Okay. But when it will become a pre-pregnant uterus? How many weeks? Pre-pregnant stateல post delivery ஆகிறதுக்கு 6 weeks. Okay. Yes. Right. So next we'll go on to abnormals. Okay.